Thank you so much. Hi, good afternoon. It's really a pleasure to meet such a group of expertise, people who are really specialized in internal medicine, um, which will fulfill the collaboration between internal medicine and emergency medicine, which we always need your kind expertise in our patients, and we will be. This will ensure also the always collaboration between both departments and how we can offer our services as an emergency medicine. So today, uh, this is our flagship hospital for Burjeel Holding, Burjeel Medical City, which we all are proud and we are looking for to develop more and more. Um, Moving on to our lecture, which is about acute abdominal pain. Uh, the reason of this lecture is not to make you, it's not to be giving more of information as much as it is giving an up to date of points that will help if it will refresh part of the expertise that I'm sure you already have. And also it will connect with any new information I hope that I can deliver today. Um, we will start with some case presentation. Then we will move on, dive a little bit with epidemiology and pathophysiology for acute abdominal pain. We will talk about some differential diagnosis for acute abdominal pain and a special consideration for four diseases in Ramadan. For sure that the approach to history taking and physical examination in patients with acute abdominal pain needs special expertise and how to approach those patients. Imaging choice in some of these diseases that are coming with an abdominal pain, and finally the disposition of those patients and how we can make a better collaboration between emergency medicine clinics as outpatient and emergency department. We will start with the case presentation of about 24 years old man with no past medical history. He came with sudden onset of left lower abdominal pain, and it's just started 3 hours ago with some recurrent vomiting with normal vital signs except for tachycardia. When you look at the patient, you feel that he's too young to have diverticulitis while you're working him up. And at the same time, since the pain is on the left side, you doubt there is an appendicitis. A urine analysis done, which showed negative for blood, which you will say this is less likely to be a renal colic. An abdominal pain is still common, and its presentation keeps presenting to our emergency departments and even to the clinics, and but it's still making a complex challenge to us. We call it always in the emergency field as a dark side of the moon. It's always vague, and we hope sometimes that it comes like as the text box is talking about. Therefore, having a structured approach, it will help recognize those high-risk patients and selecting the appropriate testing and using flexible clinical pathways, which is we are looking forward always in the emergency department to develop and how we can approach those patients. Between 2007 and 2011, there was noticed an increased visits of 23% to ED visits with abdominal pain. Patients' rate of admission has already considerably increased from 18% to 42%. And the incident in elderly, which is above 65, as they say, has increased also. And they found that 60% of elderly patients with abdominal pain are already hospitalized, 20% undergo surgery, and 5% unfortunately die, which is also causing that the high risk and the special category of age with abdominal pain. Talking about pain itself, it has two components, which are the visceral pain and the somatic pain. as we all know that the visceral pain start to be vague and poorly localized, and it occurs from distension or inflammation of a hollow organ. Then moving on, the somatic pain will start to show more localization. Uh, the peritoneum, but what we need to know that the peritoneum, by aging, is become less sensitive. So we might not see those, especially in patients with appendicitis or bowel obstruction, or we will not see the usual um, examination that it is not should be. Why we seeing it in young patients or middle-aged patients? Differential diagnosis of abdominal pain, as you can see to the left side, it's about what exactly is the true diagnosis, and the first one is the initial diagnosis. Here I want to point out something that we're starting increasingly to see that abdominal pain is being diagnosed finally with a gastroenteritis, which is becoming more of a scary to us in emergency department. Um, Now we are starting to move toward to show that this is a non-specific abdominal pain or abdominal pain of unknown etiology. Because as a clinician in the emergency department, we consider ourselves that we're doing our best to the patients, but at the end, we might diagnose, we might not diagnose. We are not diagnosticians. But as long as you all know that if the abdominal pain is not a surgical type, then we can move on by either consulting, we dispose, we admit, we send to clinic as a referral. So we started to keep telling our physicians who are working in the emergency department, put the gastroenteritis to the side, leave it to the end. If you cannot diagnose the abdominal pain, keep showing it as a diagnosis of unknown etiology, non-specific abdominal pain. So you keep yourself in the gray zone and you keep tracking all the possible abnormalities or possible problems that might happen to the patient, might affect their life. And as you can see, that differential diagnosis is really broad, which is from systematic, infectious, neurologic, toxic, thoracic, as well as abdominal pain and genitourinary. I just tried to put some of these slides regarding the Holy Ramadan. I did my best to search the PubMed and to look at how Ramadan might affect some of the diseases, especially in the gastrointestinal disorders. So most of these studies were done in countries with Muslim countries, or countries with a majority of Muslim or high percentage of Muslim populations, starting from microbiology, which is showing to increase lipolysis and fatty acid, free fatty acid, decrease LDL, and decrease HbA1c. As you can see, also it might cause increase in white BCs, RBCs, and platelets levels. There is also noticed to have a decreased inflammation and pro-inflammatory cytokines. And there is an observational study, which is people who are fasting, they found to have a low blood pressure, systolic and diastolic. So we can expect that in those patients. It's not a rule of thumb, it's not a guideline, but we have to consider it. And as you can see in the last one, which is there is a profound impact in the circadian pattern of the body, which is also affecting the hormones that we're using, especially for melatonin, sometimes for cortisol as well. There is also a decrease in the growth hormone concentration, as well as there is also a remodeling of the gut microbiome with intermittent fasting. And during fasting, when the body is in mild state of nutrient stress, And the cellular process is always going from growth to repair. That's what they found. We will talk about four most common problems that we face patients, especially in emergency department, and you might face it also in your clinics, uh, about the relationship between these diseases and Ramadan. For IBD, especially ulcerative colitis, and people show there is a significant increase in partial Mayo score, and this score is used for people who are in remission. Patients with mild or uncomplicated disease has a low risk, similar to Crohn's disease. Elderly ulcerative colitis, unfortunately, they found that they have a flaring in their disease status, and they might require further evaluation, different from the other age groups. So for IBD patients, there are risks with fasting that needs to be discovered, and so particular attention should be given to elderly with ulcerative colitis patients. For peptic ulcer, as we all know that it is caused by H. pylori and NSAIDs, during Ramadan, there was a significant increase in duodenal findings, especially duodenitis and duodenal ulcer. There is also a finding that surgical intervention and for perforations especially, it has increased. So what we can say that these studies, where it has its limitations, especially in the way that it was conducted. I'm happy to share all the limitations that were, but it's like a general overview of what they found also. So it's always very important to provide counseling for those patients with these diseases and the potential risks and benefits of Ramadan fasting. So it's very important to have a close monitoring for those patients and when to attend the medical attention. Gastroesophageal reflux disease, aggravating factor, as we all know, obesity, older age, analgesics, smoking, alcohol, and caffeinated drug, as well as psychological stress. It's found that in GERD, it's by Ramadan, it's decreasing. So esophageal reflux disease, it's getting much better during Ramadan because of mostly of the cessation of the coffee, especially for people who are alcohol advocates. Also, it will decrease the use also of alcohol. Also, there's a decrease of cessation of smoking. And fasting is ultimately safe with that. For non-alcoholic fatty liver disease, there is a decrease also found to be had by the end of Ramadan with a BMI, glucose, ALT, AST, GGT, and alkaline phosphatase. Patients with mild cirrhosis, they found that they are safe to fast during the Ramadan. And patients with more severe cirrhosis, they found that they should not because it poses risks to them, to their lives. Now we will move on to how we approach those patients with an acute abdominal pain, and at the same time by history taking and physical examination. I will try to give just like pinpoints that will help in how we can approach those patients. In our emergencies, when we are looking at any patient who's coming to us with an abdominal pain, the first question we will ask ourselves, what might affect my patient's life? So we always look in any abdominal pain, is it surgical or not? At the same time, is it really something I need to interfere right now? Or the patient can be delayed and given some treatment and referred to clinic? History taking questions may help identify high risk patients, but they still, as we said in the beginning, it's a dark side of the moon. We are still facing whatever you are doing for those patients, trying to help, diagnose, doing all the images that are needed. By combining the physical examination, history taking, and even investigations, we are still posing at risk in missing some of these abnormalities that might be there. There is just a tip I would like to add, and especially for the patients with an appendicitis, and which is the speed bump sign. Mostly they found it has a sensitivity of 97%, specificity of 30% for diagnosing of acute appendicitis. So when the speed bump sign is about when you are in the car while you're traveling to us, when you go into the street humps, the speed breakers, at that moment you have a worsening in your abdominal pain. So they found with this study that it is really about sensitive over 90% if the pain got worse. It's just like a hint for the history taking. Always in our physical examination to start with vital signs. And we need always, when we are in doubt for those patients with temperature, if the patient having a fever or not a fever, always seek for rectal temperature. And you need to be aware that oral temperatures are falsely low in patients who are rapidly breathing. 30% or more of those elderly patients have an active infection, may have little or no fever. We're increasingly now relying on shock index. And this shock index is really a powerful tool to tell us, is this patient at risk or not? Is this patient might deteriorate quickly or not? And we found if it is more than or equal to 1 is really a specific predictor for having a deterioration. Regarding palpation, they found also even in appendicitis, 20% of those patients might not have a right lower quadrant tenderness. There is also a study about left-sided appendicitis, and especially in people who are with malrotation. When they looked at those patients, and they found that this is really, there is a rebound tenderness. Patient, it's on the left lower side. And at the same time, they have the classic symptoms of nausea, anorexia. Pain is in the middle, then it's migrating to the left lower abdomen. So how do we know that? Most of the time, we cannot know it exactly just from the physical examination. For sure, you need to move on with your additional imaging and additional blood tests. But they are saying, like, as a hint, just try to palpate the chest on the right side. If you see that there is a maximum impulse which is compared to the left side, that means there is a malrotation for those patients, congenital. Always, it's already testicular examination in male patients, which is always it's somehow overlooked, and many of the physicians, they don't examine that, which is posing those patients to high risk of testicular ischemia, and it's more of legal as it is to surgical and high-risk surgical condition.
Doctor, we have 1 minute left. 1 minute left.
Interesting. So I will move about some of these diseases we have, which is acute appendicitis. Everybody loves CBC. We're still in emergency. We will say, why do we need CBC? I want to see the white VCs, but unfortunately, we are still skeptical about the white VCs and the CBC. They use it as a surgeons. The surgeons like it in Alvarado score, and sometimes they use the CRP with it modified, but there is no specific test will tell you what is exactly the diagnosis. The most important is the CT scan. Ultrasound, sometimes it is done based either if insurance needed. Sometimes we are not convinced as an emergency physician to do it, but we have to do it. and ultrasound also in pediatric patients. MRI is the second line test after ultrasound in pediatrics. Bowel obstructions, we can find in x-rays a 50 to 86% the obstruction might be there. CT scan is identify transition point, and if there is a high risk for a mass, especially in geriatric patients, we need the CT scan. Ultrasound also, it's sensitive in 94%. Biliary tract, as we all know, ultrasound is the gold standard. If we need in a CT scan, we are looking for common bile duct stone, and MRCP is as if it is available in the current hospital you're working with, and ERCP is to diagnose and to treat. Diverticulitis, most of the time we can diagnose it by using ultrasound, moving on to CT scan, but the purpose mostly for CT scan is there any microperforations, we need to move on and start consulting surgery. Pancreatitis, amylase started to fall out of favor from many of the laboratories and even in the studies. We're now more focusing on lipase, and which is more specific. CT scan is done if we are looking for gallstone that is causing pancreatitis and pseudocyst or abscess formation. They are advocating for Lely to do any imaging for patients with alcoholic pancreatitis. KUB X-ray not recommended anymore. KUB ultrasound to detect the stone. Unfortunately, the ureter is part of it is falling in the retroperitoneal, which in the ultrasound we cannot find it. CT KUB is the gold standard now for stones. UTI, bacteriuria is mostly fairly sensitive for UTI. False positive and false negative also occur. Leukocyte X-rays is more sensitive than nitrites, but not specific. Nitrites is more specific than leukocyte, but not sensitive. High WBC is fairly sensitive for UTI in adults. Now for the final point, it's about the disposition between internal medicine clinics and the emergency department when we're facing those patients, and how we can improve our relationships as to both departments who are seeking patient safety and at the end also delivering the best of the treatment for those patients. It's very important to have, if we are moving patients between departments, is to have a fairly timely and effective communication, which is also being documented in our EHR if our hospital is equipped with that. There is also a clinical handbook of protocols, which is depending on ISPAR. It's not only for nurses, also for doctors. And at the same time, it's very important to have a message from the internist that this patient I feel he's at high risk of patient. That's why, because many times of the emergency department, especially it's unpredictable patients flow. And many times we are facing a sudden flow of patients that we don't have enough beds. Securing those beds for patients who are at high risk is very important to us. So we can accommodate them as soon as possible, moving them inside and make sure that they will be seen by the appropriate physician as soon as possible. Coordination is very important, and at the same time, patient education and involvement, which we are still facing. Why I'm here, why they brought me to you, what do you think I have? I have many other questions. This is just an important to give the patient some insights why you're going to the emergency department. Following up to having an implemented system to track the outcome of the referred patients. We track some of the referral system from our side as an emergency to the outpatient clinics, but also implementing the tracking and referral system from patients who are moving from the clinics to the emergency department is very important also. Training and awareness of the staff is very important, as well as having quality improvement initiative, which can be by ideation or brainstorming. It can help in moving on and establishing the patient flow protocols between the outpatient clinics and the emergency departments. And the final, I will just finish with a case to continue. So the patient, the physician moved on and tested the testicle, which they found there is a tenderness in the left testicle, and they did an ultrasound and they found the patient has a testicular torsion. They immediately called the urologist and moved the patient immediately to the OR for detorsion and surgical intervention. Thank you so much.